We've got Dr. O from Mary Bridge and an MSO from TFD, Jeff Bambrick, in the back kind of observing today. They've both had an integral role in creating one of the things that you'll see in the second half of the class. So we want to thank them for being here as well. But basically today is about how do we make paramedics irrelevant, right? So we're going to give you tools to do that. One of those tools is an eye gel. All the EMTs are being trained to place eye gels on patients as your first airway, specifically in cardiac arrest, but we'll show you other instances where it might be applicable as well. When you leave here today, you will be checked off to do that. However, make sure you hear this, nobody gets to do this in the field until every EMT in the department gets checked off. So it's probably going to be sometime end of February, middle of March before we can get to everybody, and you'll be notified when that go live is. All right? Slip and all right, slip and fall. So I'm going to spend about half an hour going over iGel PowerPoints, then we'll break into some different groups for about an hour and we'll get practice at it. Then we'll come back together and Curry will deliver about an hour-long presentation on the pediatric out-of-hospital cardiac arrest study. And then we'll spend about an hour and a half doing different scenarios on that. All right? So there'll be some in and out, up and down, but we won't kill you with PowerPoint too much. So let's get going. Any questions? All right. Anybody had this class yet? One. All right, perfect. Okay, so as far as the iGel portion of the class, basically we're going to spend the first part of this doing a BLS airway refresher, right? Making sure that we're going over the things that you guys mostly already know and do, and just fine-tuning them a little bit. We'll talk about indications, contraindications of the iGel, how to insert it, and then how to manage the device. So first, when we walk up to a patient on scene, it's ABCs, right? So we need to look at our ABCs, and a primary breathing survey is going to include things like, is the airway patent? How about their oxygenation and their ventilation status? Is it adequate, right? If they're breathing, getting a good set of lung sounds so we can get a quality marker of their ventilations. So if we look at this and we go, let's see, is the airway adequate? If I hear snoring on a patient, then I know this is likely a positioning problem, right? So let's open the airway, right? Whatever space we gain in there to open that airway, let's keep it with something, maybe an MPA, right? If we see gurgling or hear gurgling, we see fluid, it's probably a suctioning problem, right? We still want to position an airway, but we really want to focus on suctioning and seeing if we can clear that airway to make it patent. So there's a lot of ways that the airway can be obstructed. Number one, first and foremost, is the tongue. You lay somebody on their back and you render them unconscious, unresponsive, that tongue is likely to fall right down and occlude that airway. If we don't open that, we can't deliver any oxygen. We can't ventilate. We could have foreign body aspirations. So as BLS providers, take a look in the mouth. If you see something, you can remove it. You can't go in with McGill's and pull it out. If they're unconscious, unresponsive, BLS provider, we do chest compressions, which is strikingly similar to CPR, right? Laryngeal spasms, the vocal cords could spasm and essentially occlude the airway. Not a lot we can do. I've got a little tip here that may work sometimes, I can show you. Any sort of edema or trauma in the airway, burns, anaphylaxis, distorted airways from trauma, right? Those are all things that can cause airway obstructions. So if you see things in the mouth, do your best to get them out with suctioning, finger sweeps, rolling patients on their side. Ventilation, is it too fast? Is it too slow? Is it too deep? Is it too shallow? And then what's the rhythm, right? Is it regular and normal, or is it irregular? So that's how we can assess the ventilation. Oxygenation status, we basically put on an SpO2, right? We look at their waveform, we put on an SpO2. Generally speaking, if it's in the mid to upper 90s, we're not too concerned about that. But we need to confirm with our waveform, that pleth waveform. We can't trust a number unless we have a good waveform, right? Do they look cyanotic, or do they have signs of air hunger, right? Maybe somebody that has a PE, they just are saying, I can't get my breath, but they seem to be ventilating fine and maybe even oxygenating okay. But when they have oxygenation problems, it's a pretty easy fix for us mostly. In EMT school, we're all taught to throw on a non-rebreather, turn that thing up to 15 liters a minute, and we're going to give them close to 100% oxygen, and that's not anywhere close to the truth. So patients that have difficulty with oxygenation, we need to make sure that we're giving them more oxygen. We want them to breathe in close to 100% oxygen. And the only way to do that is with high flows. So if you're in the rig, you can throw a mask on them and you can turn that thing up to flush, and it's going to go much higher than actually what the tree reads. But our regulators only go to 20 or 25, right? So we may need 2 oxygen sources. And if you have any doubt in your mind that this patient may end up needing to be intubated, let's get a nasal cannula on there because we can use it later down the road. Turn the nasal cannula up to 15, a non-rebreather up to 15. The vast majority of our patients with an open airway will have better oxygenation. And now that cannula is on later on when we go through intubation process. So I'm not going to go deep into causes of respiratory distress. We could be here for a week, right? But basically upper and lower airway obstructions. We've got patients that just aren't breathing. They're not moving air back and forth. We may need to help. We could have an impairment of respiratory muscles, right? Some paralysis, things like that. We could have a nervous system problem, right? C1, C2 fracture. And then there's books and books on airway management. Again, this is a very quick 15-minute refresher course for you guys. So number one, first and foremost, we touched on it, we open the airway, right? The easiest, fastest, successful way to do that is just a head tilt chin lift. If we're worried about cervical compromise, then we do a jaw thrust, right? Let's move that jaw forward. This is where there's a little bit of research that says this Larson's point, if you take your 2 fingers and you put it right underneath your ears nice and high, and you just push in, you'll feel that moves your jaw forward really nice and easy, all right? When you move that jaw forward, you tend to open that airway as well. You can do 3 things with this. You can open the airway. You can also check for responsiveness. If you push nice and hard, it's a painful stimulus that's kind of hidden too, right? And then 3, if they happen to be having some sort of laryngeal spasm, that pressure point may relieve that, right? So you've just improved a possible obstruction. So this is just a picture of somebody laying flat on their back with their airway blocked by the most common obstruction, the tongue. A simple head tilt chin lift. You can see the space and the gap that's made there. Once we make that gap, we need to maintain that gap, and we do that with mechanical airway support. Most simply, an OPA or an MPA. If you're going to place an OPA, measure from the corner of the mouth to the ear. You place it in, you turn it as you go in, and you hold that tongue away from the back of the oropharynx. We typically tend to use an MPA a little bit more often. We measure from the corner of the nose to the ear. Make sure you lube this up. Let's look and see if we can get that bevel end to go towards the septum. And we want to place this nice and slow, right? The one thing we want to really avoid is causing a nosebleed and now having to deal with blood in the airway. So nice and slow, take 10 seconds, 15 seconds if you need to. Look at their nares. Generally, people have one that's bigger than the other. Go for the bigger one. And if you need to rotate it to get that bevel in the right place, that's good. Severe facial trauma, maybe hesitation on placing an NPA. But if one MPA is good, 2 is probably better. And if you're still having problems with oxygenation, throw in an OPA, right? If there's a hole, fill it with plastic. It works really well. So we'll move on to suctioning a little bit. We've got 3 different types of suction, but these 2 different catheters, we've got a rigid catheter and a flexible catheter. The short story is a flexible catheter is used to maintain devices, right? So it's used to maintain an iGel, it's used to maintain an ET tube. A rigid catheter is used to suction out the oropharynx, right? So anything that you can see as a BLS provider, you can suction out of the mouth, right? So that would be a rigid catheter. If you place a device like an iGel, we need to be able to maintain that device. That's going to be your rigid suction, or sorry, your flexible catheter. How many people have used a VVAC any time in the last several years? Yeah? Okay, so I don't have a ton of experience with the VVAC, but on an engine, this is your form of suction. I've learned through the course of teaching this class that this tool is, I think, far better than I give it credit for. But there's a couple tips, right? This can be a 2-person job. One person goes to town on that canister and just squeezing the handle, right? The other person is directing where it needs to go for good suction. This tip right here, the large tip, can actually fit into the top of an ET tube. You can suction an ET tube with that. There is an adapter that goes on there that comes with a semi-rigid or semi-flexible small tipped catheter. That should be used more for blood, fluids, thin things like that, right? That large tip more for chunky stews and soups and vomits. If you fill this canister up, let's say you're just suctioning constantly. This door right here, you can flip that open, and if you continue to suction, it will push out all the fluid that's in there, and it'll just hold on to the big chunks, right? So this is actually quite a useful tool. There is also a double male adapter that we can attach a fully flexible catheter to, and you could theoretically use this down in an I-gel or an ET tube as well. So ventilations, face mask ventilations. I will say that this is not taught very well in my experience. We're not very good at it, myself included. And if we can get better at this, and if we can be fantastic at face mask ventilations, many of our airway problems, we can buy ourselves a ton of time to take the appropriate steps. So we're going to practice this today as a review at one of the stations. But when do I use a BVM? Well, if somebody's not breathing or they're not breathing enough, right? That's a really good clue to pull out your BVM, especially if they have an intact gag reflex. We're not dropping an I-gel on these patients, right? If they have a gag reflex that might be absent, but they have a problem that we think we're going to fix over the next 3 to 5 minutes, this might be a really good patient to continue to face mask ventilate as well. Overdoses, hypoglycemics. So as far as how I want you guys to do this, when you pull out a BVM to ventilate a patient, I want you to grab this mask and disconnect it from the BVM at first. Research shows that if you place this by itself first, you're much more likely to get a seal. And how I want you to do that is to grab the mask, the nose is facing towards you, pull it open and place it on the patient's face and let it come back together. We can grab all that tissue, pull it in, and you've got a much better chance of having a good tight seal, okay? But also put your hand in the right spot. Look at the mask. It needs to fit from the bridge of the nose to in between the lip and the chin, right? If it's not fitting right, we have 3 different sizes. All 3 sizes are quite different, so generally speaking, if you have the right bag, you're probably going to have the right mask, but know that you do have 3 different sizes in our airway kits. What we're classically taught is the EC method, one-person BVM technique, thumb and finger around the top, these 3 fingers underneath the angle of the jaw, pulling the jaw into the mask, and you can squeeze the bag. It's horrible. It doesn't work. We don't want to see you do it. 99 times out of 100, don't do it this way. The problem is this side of the face, generally you don't have a good seal on. You're using 3 fingers that are pretty weak all by themselves to pull this mask, pull the jaw into the mask. And so what we tend to do is we just push it, right? Which closes the airway, right? So we want to get away from this method. If you have 2 people, we need to manage face mask ventilations with 2 people. A double EC technique is better, but it's definitely not the best. What we'd like to see you guys do is the thumbs up grip, right? So when you pull this mask and you spread it apart and you put it on their face and it comes back together, your thumbs are right where they need to be. Reach down with all 4 fingers on both sides of the jaw and pull the jaw up into the mask. The seal is going to be maintained. You can do this for a long period of time. You just have to have somebody squeeze the bag, okay? So if I'm going to ventilate a patient, how much? How fast? 10 to 12 breaths a minute. So if you think of an adult, 1 breath every 6 seconds. Pediatrics, 1 breath every 3 seconds, right? We don't want to overventilate patients. If anything, maybe slightly underventilate. We cause a lot of problems by overventilating. Tidal volume, chest rise. That's all we're going for. These adult bags are about 1,200 cc's, and average adult breath is somewhere between 600 to 800 cc's. Let's come in slightly below that, maybe 500. Let's think of 1/3 to 1/2 of a bag. 1 hand squeeze, not 2. Right? If you see somebody bagging with 2 hands, give them a friendly reminder, hey man, 1 hand's all you need, right? 1/3 to 1/2 of the bag. Why is the bag so big? That's a great question. I don't know. There's some places that are going to bagging patients, adult patients with pediatric child bags. I wouldn't be surprised if we see that at some point. End-tidal CO2 monitoring is not just for I-gels and ET tubes. Let's use it every time we face mask, ventilate a patient. Let's add an end-tidal filter line on here. It'll let us know if we have a good seal. It'll let us know the quality of ventilations that we're giving, and it'll let us see if there's anything changing with that patient. Gives us more information. Viral filters, use them. We found out just the other day from physio, the end-tidal filter line, the actual filter that's in that tube, will filter out coronavirus and small particles like that. So it doesn't ultimately matter which one is first. We've always taught that the closer to the source is where we want the viral filter. But if you're having issues and you swap it the other way around and put the end tidal on first, that's okay. It still has a filter in there. Just know, if you take anything off, you don't have that filter there, okay? So let's do a quick talk, couple mnemonics. We'll go through them pretty fast, but basically when you come up to a patient and you have to help them with their ventilations, you need to know if maybe they're going to be hard to face mask ventilate or maybe they're going to be hard to place an eye gel. So the first mnemonic is Roman. The R stands for radiation and restriction. Patients that have had radiation to the neck, they've got a lot of scar tissue. They've got a lot of tissue that is not going to be compliant. And it's going to be difficult to position their airways in an area that may keep them open. As far as restrictions, we're talking about the lungs mostly. Can I get lung expansion? What would be causing a lung to not be able to expand, right? Is it the diaphragm's pushed up, right? Pulmonary fibrosis. Are there things that are going on with the patient where I just can't get lung recruitment? Triple O, obesity, obstruction, and sleep apnea. We know that large, overweight people are difficult to face mask ventilate. It's hard to sometimes even get your hands around their head, right? It definitely becomes a two-person job without question. They have just so much redundant tissue, right? They're not just fat on the outside, they're fat on the inside too, right? So these airways become smaller and tighter, so it makes it more difficult. Obstructions, we've already talked about obstructions. If you have something in the way and it's blocking airflow, we need to remove that, right? So as a BLS provider, it's finger sweeps, it's suction, it's getting an ALS provider in here with some McGills, it's doing chest compressions on unconscious patients. Mask seals. Good luck getting a mask seal on this guy with a beard, right? So you have to get creative. The only tips that I can really give you is if you have the ability to put something over his face and make a slit where you can put air through, a halo chest seal may help make a mask seal on this guy. I've seen pictures even in EDs where they've wrapped plastic wrap around a patient's face and made holes for air to go in and out so that they could create a seal. So you're going to have to get creative. We certainly don't have any way to shave that guy. He might be a really good candidate for an eye gel, right? If you're old, all the tissues of the upper airway, they've lost elasticity and makes it harder to face mask ventilate. And you've also tend to lose your teeth. So if a patient has dentures in and your strategy is to use a face mask ventilation, leave their dentures in. Don't take them out. If you intubate, we probably want to remove those, but don't throw them down the hallway. Let's keep them close in case we can put them back in and allow them to stay if we have to go back to face mask ventilations. Another tip is if they don't have their dentures in, you can roll down that bottom lip and you can put the mask inside on their gum, and that may help create a seal. So quick mnemonic for supraglottic airways. There's one right up front here, Randall. Rods for placing supraglottic airways. So restrictions again, but this one includes the mouth. If you look at their mouth and you're not able to open that mouth enough to get the device in, it's not going to work, right? Whether it's wired shut or they have other issues. Obstruction and obesity, same thing with the BVM. Disrupted and distorted airways, trauma, any sort of abscess, edema in the airway, whether it's genetic or not. You don't know exactly how that mask is going to fit around the larynx, right? And if you can't make a good mask seal around the larynx, just as with the face, you can't ventilate well. Patients that don't have a chin. Not only are these patients hard to intubate, but they're also difficult to put an eye gel in. Their tongue takes up so much space in their mouth, it may make it really difficult to get around the tongue to get the correct placement. So looking at all these things gives you a clue on how successful you're going to be with your airway strategy. So when do I go to a supraglottic or an eye gel? And this is kind of the meat and potatoes of this class. So for us, if they have a failure to protect their airway, right, that is a patient that may be able to receive an eye gel. If they are in cardiac arrest, that is a patient that needs an eye gel right away. Contraindication, if they're awake and talking to you, let's hold off. If they have intact reflexes, airway reflexes, let's hold off. Those are pretty obvious, right? Fairly simple, straightforward. I do want to point out, use extreme caution on unconscious patients where your interventions are likely to fix that in a short period of time. Heroin overdose, hypoglycemic, postictal seizures, those types of patients where you're like, you know, I fully expect with our treatments, we're going to be okay. that's a great time to practice your 2-person face mask ventilations. So limitations, we talked about most of these, but I do want to just touch on the high airway pressures. COPD, asthma, CHF patients where we need to create more airway pressures. That could be a limitation of an iGel. We can definitely create better pressure with ET tubes. So for the medics in the room, if you have that kind of physiology, let's be thinking about getting an ET tube if that'll help you out. So this is essentially the state sheet that we're going to be going through in the back at our breakout session. I've got a quick video for you guys to watch that just demonstrates exactly what you'll be doing back there.
Yeah, I've got a patient who's unconscious, unresponsive, no reflexes, doesn't have any gag reflexes. He's got no obstructions. I'm going to assist his ventilations. So I'm going to size an NPA, corner of the mouth to the ear. Apply some lube. Place the NPA in bevel side towards the septum. Grab a mask with a HEPA filter attached to it. And a BVM. I have a 2-person airway technique. Thumbs up, I'll hold the airway open. My partner's gonna bag 1 breath every 6 seconds or about 10 a minute. I'm looking for chest rise. Got good, nice chest rise, keeping a nice, good mask seal. I'm told the patient goes into cardiac arrest. So I'm gonna stop bagging with the mask and we're gonna set up an iGel. I've pre-sized the patient, he's a size 3. So we'll get the yellow iGel out. We're gonna lube the iGel. Making sure we put lube on the spine and down around the edges, making sure not to get any lube in the open port. We're gonna do a head tilt, chin lift, open the mouth. We're gonna place the iGel until definite resistance is felt. And at that point, we're gonna attach the bag and the HEPA filter. Have a couple quick breaths. I get chest rise. I'm also going to attach my end tidal. And then I'm going to confirm placement with my end tidal waveform. 1 breath every 6 seconds during cardiac arrest. I've got good waveform. I've got some condensation in the tube. His teeth are on the bite block near the black line. And I'm going to go ahead and secure. Making sure that we've got good posterior pressure on the iGel so it stays seated. And we'll just continue to monitor end tidal, making sure I'm not hyperventilating. Only squeezing about 1/3 of the bag once every 6 seconds.
All right, so that's the station back here after we break out, where you guys will all get checked out. This is also the station where you'll sign your class roster. So that'll kind of give you credit for the class as well. So you guys have all seen iGel. We've had them for a few years now. But just as far as the pieces and the parts of this thing, here's the hooks up top. This is an O2 port right here. This is the bite block where their teeth are going to be somewhere near that black line if it's properly sized. This is hole right here. That's where the air comes out. The tip of the iGel, this bottom part, is what goes into the esophagus and occludes the esophagus and ensures that air only goes into the trachea. And then there's a gastric channel right here at the bottom that runs all the way to the top where we'll place a suction catheter to help maintain that device and relieve any air or abdominal distension. So as far as selecting the right iGel, officially iGel recommends that you do this by weight. So it lists all the weight, it puts you in the range. If you want to think about, for ease, the 2.5 to a 1, these are our pediatric sizes right here, right? You'll be told which one to place based off of your pre-arrival instructions or a PEDS dosing card. The 3 is going to be your large child, maybe that 9, 10-year-old, but very small adult range. And then your 4, generally speaking, is women, and 5, generally speaking, is men. There are some differences between these. As you can see, none of the pediatric ones have a hook, right? So how do I secure this? Well, we secure it with tape, right? We start high up on the cheekbone, and we wrap it high up on the eye gel, making sure not to get on the connector. Nice circle back to the opposite cheekbone. If they're sweaty and wet and you need to wrap it around their head, that's fine. With all the adults, we have the strap that you saw. The pediatric ones also don't have an O2 port. So on the adult ones, make sure that O2 port is closed. We don't want to have a leak or something there. And then the other difference is what size suction catheter they'll take. For ease, if you just think they take a size 10 French suction catheter in that gastric channel, it'll fit in all of them. Obviously, if you can remember which ones take what, the bigger suction catheter we can get, the more effective that's going to be. Also, body weight on these individuals is ideal body weight. It's not total body weight. So every large person has a normal sized person inside of them. Try and figure out what that person looks like and base your weight off of that. So once we've placed this device, we have to maintain it, right? So a couple tips for insertion procedures, just to recap that video. Lube the spine and the edges. You can lube the front part, we just don't want lube inside the little tracheal hole right there. Brownie points, if you attach a viral filter while you insert that thing, perfect. Hold the cuff so it faces the patient's chin, right? So the open part faces the patient's chin, and when you're looking at it, you should see the weight, you should see the size, and you should see the black line facing you. Open the mouth, take a quick look for obstructions. If you need to suction because their mouth is full, do that. Remove any obstructions, then place the device in. When you introduce the eye gel along the hard palate, you're going to start to slide back. You're going to feel a little bit of resistance as you get past the corner of the tongue. You want to push through that, and then you'll feel it kind of give way until you meet a definitive hard stop. That's the eye gel seating inside the esophagus and creating a seal around the larynx. So when you feel that definitive resistance, you know you're in a good spot. If it's sized properly and you have it placed right, the teeth should be very close to that black line, plus or minus just a little bit. You want to make sure you secure. One of the biggest problems we have is we don't secure it tightly enough and it just moves around. Just like a face mask, if you don't have a seal, your ventilations aren't effective. If you don't have a laryngeal mask seal with that eye gel, your ventilations won't be effective. So keep posterior pressure. And then always, always, always attach an end-tidal CO2, just like we do an ET tube, right? That's a gold standard confirmation that we're delivering effective ventilations. And then continually assess your bagging, right? If your bagging starts to get hard, maybe I need to place a suction tube down that gastric channel. So a couple tips, pre-suction the airway. The cleaner that airway is, the better the seal is. If we place the patient in flex tension, we can kind of get that airway open for us, right? Which just simply means we're going to bend the patient's head forward and put their face up towards the ceiling. So this sniffing position that you've heard it called, that helps open that airway a little bit. That may help. Attach the viral filter. They do recommend this deep rotation method. If you have a hard time getting around the tongue, you can kind of go in on the side of the mouth and see if you can then rotate around it. So that's another technique you could use if you're having difficulty. So confirming and maintaining. End-tidal CO2 is number 1. If the patient is breathing and we're not doing chest compressions, let's look at chest rise to make sure we're getting good ventilations in its appropriate amount. If we want to listen to their belly, great, we can do that. Make sure that we're not getting any bypassed air into the esophagus. We want to establish some lung sounds. Do we have good bilateral lung sounds? And obviously we should see an improvement with our SpO2. And then bagging compliance. You place this, you start bagging, you're like, oh, everything's really easy and nice. And then all of a sudden it kind of starts to get a little harder and a little harder. That may indicate that we've got some sort of obstruction issue. So with the end-tidal CO2, this is a waveform of a perfectly healthy patient, right there. 35 to 45, nice plateaued waveform. We don't place eye gels on perfectly healthy patients very often, so you're likely not going to see that waveform. You may not even see a number between 35 and 45, that's okay. We're not verifying our placement based on the waveform or the number that you see. We're verifying our placement by the fact you have a corresponding waveform with your ventilations. That's what we want to see. That tells you you're in the right place. Doing CPR, you're going to see a waveform that looks a little bit more like this, right? So you're going to see a waveform that's going to correspond not only with your ventilations when you get a big rise, but it's also going to correspond with your chest compressions. So as you're doing compressions, you're typically going to see a bump in this end tidal. After a ventilation, you'll see a big bump, and it'll kind of stair step down until your next ventilation. So expect to see that. SpO2, we talked about the waveform. If I have an artifacty kind of waveform, I can't trust the number no matter what it says. If I have a good pleth, a nice good waveform that matches their pulse, that means I got good perfusion to the extremities. That means I've got a good heart rate. I can trust that waveform, except in the absence of things like anemia, carbon monoxide poisoning. If I'm having difficulty getting a waveform, it may be due to hypothermia, poor perfusion, cold at the fingertips. So when we treat a patient in respiratory distress or cardiac arrest, we want our monitor to look like this. Forget the temperature, we don't have that ability. But we want the top line to be an EKG quality waveform. We want the middle line to be our SpO2 waveform. We want the bottom line to be our end tidal CO2 waveform. Everybody can look at that monitor and know what we can trust on there and what we can't, and what we need to fix and what we don't. So to jump back at this gastric channel, we've taught you guys, or we're teaching you guys to place an I-gel, so we need to teach you to maintain it. However, EMTs are not allowed to do gastric suctioning, and you're not allowed to do tracheal suctioning in this county. So what we want you guys to do is when the need arises to place a gastric tube in one of these devices, which is going to be frequently, we want you to take a flexible suction catheter, appropriately sized. Just measure your package right there. You'll notice that the package, the size of the I-gel is very, very close to the size of the resus package. And then you'll insert this into the gastric channel. If you feel resistance, you stop, right? If you get to the place where you marked, great. What you're doing is you're maintaining the device that you've placed, right? We're not actually doing gastric suctioning. Same thing with the tracheal tube. If the tracheal tube fills with bloods and fluids, measure it the same way. Insert this until you meet resistance or till you get to your mark, your predetermined mark. That way you can maintain this device. If there's an ALS provider on scene that would like to do something different, by all means, let's accomplish that.
What are you saying we're not allowed?
Gastric suctioning and tracheal suctioning are not an EMT skill and protocols.
With that in there, we just can't attach it.
No, we can put it in, we can suction, but we're maintaining the device. So we're not putting a tube all the way down into the belly or all the way down into the actual trachea, just the device itself. So the O2 port. Not too many times we're going to use this, but I'll offer you a scenario. 2 people respond to a cardiac arrest. You have 3 jobs that have to get done right away, and you have 2 people to do them, right? We have to figure something out. This is a great time where this O2 port may come in handy. If one person goes in, immediately starts chest compression, the other person grabs an I-gel right away, places that I-gel and hooks up oxygen to it, we are ventilating this patient, right? With the chest compressions, because we have an open airway and we're changing the pressure of the chest, right? When somebody else arrives on scene, have them take over those ventilations. And after you place this, that second person can go to the monitor, get the defib pads hooked up. Troubleshooting, we've covered most of this already. I want you to remember, look in the mouth first, remove any obstructions, maintain posterior pressure. If you see that strap kind of has a lot of slack on it, let's fix that. If you have difficult ventilations, that's when we consider certainly putting that gastric channel in there to decrease the size of the belly, increase the compliance of the lungs and the diaphragm to move with your ventilations. If you have a big air leak that's coming from that gastric channel, you probably don't have this seated right? So let's kind of look at that posterior pressure. The device is designed to hold the epiglottis up and out of the way, which is the flap of skin essentially that covers up the trachea, right? So when you swallow, everything goes down the right tube. The I-gel is designed to hold that up and out of the way so air can flow in. There's a chance that that thing has fallen back down and essentially created an obstruction on itself. So you may have to reseat that I-gel. If it was working and all of a sudden it stops working, we try that. Tracheal channel suctioning. The patient gets a gag and there's only BLS on scene, we need to roll this patient over. We need to remove this eye gel, okay? If you can suction while you remove an eye gel, it'll help. We want to get rid of everything that's in the mouth. We want to reduce any chance of aspiration as much as possible. If there's an ALS provider on scene and the patient regains a gag reflex, they get to make the choice. Are we going to remove the eye gel? Are we going to sedate the patient, keep the eye gel in place, right? Are we going to put it in an ET tube? Last but not least, using our auto vent on transports. It's going to cause problems. It's likely going to cause problems. My recommendation is to stick with a BVM. However, iGel does say that it'll handle airway pressures that our auto vent will deliver. We can't really adjust that too much. It may work fine, but you're going to have to pay attention to leaks. You're going to have to pay attention to increased chance of gastric insulation, putting air in the belly. I can never say that word. So my advice is to not use the auto vents. Any questions on any of that stuff? There's a lot coming at you. It's fairly straightforward and fairly simple. Yeah, Jamal.
All right, we're going to talk about the POLCA study. So POLCA stands for Pediatric Out-of-Hospital Cardiac Arrest. And the whole rest of this class is going to be focused on making improvements in the outcomes for our pediatric patients. So why are we doing this? This is one of those most stressful calls that we go on. And so when we think about approaching these calls, we want to know that we're acting in an excellent fashion and we're doing excellent care. We want to be brilliant at this. We want to feel competent so that we can be having the best outcome we can for these kids. Historically, the approach that we've taken is a scoop and run approach. A parent will come to you and hand you a limp kid, and our adrenaline goes through the roof. And we grab this kid and we go out to the medic unit and we start care, and whoever comes in the door starts in a spot wherever they can. Somebody gets in the front seat and we go bouncing down the road where we start to try to do our care. And this uncoordinated attempt is not necessarily giving us the best outcomes. It also has the setup for us to have more of an impact on us emotionally, right? These kids, if they die, and some of them will die, if we come at these things, we'll second guess ourselves and ask ourselves, did I do everything right on this call? Did I miss something? This is where we kind of think about things, and we have the potential for some PTSD. So nationally, there are about 20,000 pediatric cardiac arrests every year. And over the last few decades, there have not been any marked changes in outcomes for kids, even though we've been following the standard of care, PALS, right? We've been seeing improvements in adult cardiac arrests. In VF witnessed arrests, we're seeing some fairly impressive changes, where we're seeing 9% survival rates go up to 30% survival rates and 40% survival rates in some of the studies. But we're not seeing that in peds. So nationally, we're seeing a survival rate of about 11.5% in kids between 0 and 18. In infants, it's even worse at about 5%. So here's some of the data from Pierce County. In between 2013 and 2019, we had about 111 of these cases. And our numbers in the county are about the same as that national standard at about an 11% survival rate. Central Pierce had 41 of those 111, and our numbers are right about at that same spot at 12%. Okay, one thing I want to note is that 88% of the initial rhythms on these patients were asystole. So when we look at our care later on, that's going to have an effect. We're not shocking many of these patients, but this is kind of that reminder that the majority of pediatric cardiac arrests may be respiratory in nature. When we get to that respiratory part, here's our success rate at endotracheal tube attempts. For Central Pierce, between 2015 and 2020, we had a 42% first pass success rate and a 25% failure rate. As they get younger, we get worse at this. The bottom line is that pediatric airways are difficult airways, hands down. Unless you're volunteering at a veterinary clinic and you're getting cat intubations every weekend, nobody's good at this. We have no experts at pediatric intubations. All right. So we're lucky today. We've got Dr. O and Jeff Bambrick from TFD here that have been really instrumental in asking the question to the county, what are we going to do about this? And Dr. O has asked everybody to come up with a kind of a plan, and TFD and West Pierce and Central Pierce are working with Mary Bridge on this study. So what we've come up with is a list of interventions and key interventions that we're addressing to have that outcome. All of these interventions were found from studies where they showed some kind of an effect. So we did kind of an exhaustive research analysis, and found anything that we could that showed that there was a little bit of an improvement in having a beneficial outcome. Being brilliant at the basics, setting up a pre-arrival plan, treating in place instead of scooping and run with these kids. We spent the whole first half of the class talking about an i-gel and placing an i-gel. We want airways on board on these patients as fast as possible. So we want to minimize our hands-off time and having continuous compressions. We want to get that defib and that 10%, if it's a possible defib. We want defib on board as fast as possible. And once we have a medic there, getting an IO in place and epi on board. So American Heart Association has identified that being excellent at CPR, or anything that you can do to improve CPR, has numerous studies that show that you have benefits in the outcomes for patients. Kids, infants, adults, everybody. If you tighten up your processes at being excellent at CPR, you get end results. So as far as this study goes, these are all the things that Mary Bridge is going to be looking at. These are a lot of the numerics or the metrics that Mary Bridge is looking at. Everything is in red is the stuff that we've kind of correlated to the interventions that we're going to be looking at. So we're looking at your initial rhythm. We're looking how fast it was to the first time for the first shock. What your airway was. Did you get an i-gel, and how fast did you get it? When you got your i-gel, did you check the waveform? Did you look and confirm your waveform? How fast did you get IO access? How fast did you get epi on board? What was your dose? And what was your timing of that dose? So again, all of the interventions in the study are evidence-based. We're trying to pull as many of those interventions into one tool as we can. And the whole tool and the whole process is developed to decrease cognitive load. When we walk in and that mom hands you that limp baby and you get that catecholamine, that adrenaline rush, and your head starts spinning, and you don't want to be making your plan at that moment, right? We want to have a plan in place in our head and have excellent care in our mind when we get patient side. So this is designed at improving logistics, and anytime you improve logistics industry-wide, you see improvements in outcome. I mean, perfect example is Amazon. The better they are logistically, the more money they make, right? And the other part is improving provider emotional response. If we know what we're doing when we walk through the door, we're going to be confident that we are giving the best care that we can for that kid, and afterwards we're going to be less likely to second guess ourselves. We're going to have more of a positive emotional outcome for our responders. So what are we going to do in order to, what are we going to use? What are the tools that we're going to use to make this happen? Okay, we're going to have a pre-arrival guide. We're going to have a pediatric checklist. And this is basically designed to improve our logistics on CPR. We're going to be looking at ESO at the Lightning tab. And we're going to bring up the CPR tab, and we're going to document our interventions on this during the code. And we're also going to have a new app. We'll talk about that a little bit later, and we'll kind of coordinate that a little bit as a metronome to get us all dialed in on better CPR. So the pre-arrival guide. The pre-arrival guide and all the numbers and all the doses on here are directly out of the pediatric Pierce County dosing cards that are approved by Mary Bridge and the Pierce County EMS. They correlate with the link-based tapes and the Broslow tapes. This is all the same information. The cool part is that Mary Bridge and Dr. O has given us permission to use this for our initial actions, and this is going to have a huge effect on how fast we can get things done and our ability to approach the call knowing what we're doing. So we can set up a plan based on our dispatch information. If we're dispatched to a 10-year-old cardiac arrest, an engine officer can look on the back and say they're 10, they're in the green category. You're going to look to your crew and you're going to identify which roles that you want to take for your first few minutes of CPR. You're going to say, okay, you're going to be on airway. You're going to use the number 3 I-gel, and you're going to be using an adult BVM. And you're going to look to your monitor and the person you've identified to be on the monitor. You're going to say, you're going to be on the monitor and you're going to be using the adult defib pads. So you've given them a role. You've given them the item that they're going to be using in the first 2 minutes. They have a plan, so when they get patient side, they're not making that plan once they get patient side. They have their plan in their head and can be thinking about that as they walk up to the door. So it could look kind of like this. I'm going to show you a video of what that could look like for your engine company as an engine officer.
All right, guys, looks like we got a 3-month-old cardiac arrest. So we're gonna be pulling up here. Let's see. When we get there, I'll be the team lead, and I'll be on compressions first. Next, DeVaglio, you're gonna be on the monitor, and McDonald, I'll have you on the airway. It looks like 3-month-old puts us at gray I-gel size. McDonald, I-gel is gonna be a 1, and an infant BVM when we get started. Otherwise, we'll cover everything else when we get there.
All right, so one thing that we're not doing is I'm not telling you as an engine officer how to assign your crew. You guys know your crew better than I do. You know your strengths and your weaknesses. You know if you've got an ALS person on your crew that day, you can think about an ideal place for you to put them, right? But what we are going to do is we're going to assign the first 3 positions. These are the critical positions for the first 2 minutes of CPR. Is you've got somebody at compressions, somebody on airway, and somebody on the monitor, okay? Jack, I mean, how would you go about assigning your crew to a 1.5-year-old, so an 18-month-old patient that's in cardiac arrest? Yep. Okay, and how can you set them up for success? Give them their plan. What are they going to be needing for that to run that code in those roles? In this one, what I'm talking about is give them their I-gel size, give them their BVM size, and then go to the monitor person and give them which patches they're going to be doing. So what you're doing is you're prompting them with the tasks so that they can get rid of that cognitive load. They don't have to think about it when they get to the patient. They can already be, when they're going out to the rig and grabbing those boxes, they're already thinking in their mind where they're going to get that I-gel, then which specific I-gel they're going to get. So go ahead and assign those to those guys. Yep. Perfect. And what we want to think about is for those first 3 roles is like airway needs the size of the I-gel. They need the BVM size. Monitor needs to know which pads to use. All the other numbers are generally going to be the stuff that you're going to use, that the medic is going to use for dosing a little bit later. But for your first 2 minutes of CPR, those 3 items are going to be the ideal. All right. Any questions on the way that pre-arrival guide looks? Any questions on what the information that's on there or how it's presented for you? All right. Now we're going to take a look at the checklist. So the checklist is designed to be systematic, so that we approach CPR the same way every time. We're going to be approaching all cardiac arrests in the same way. So we're going to be using this on all adult cardiac arrests because we have 111 of these in the county for peds. The adult cardiac arrests are going to be our practice for the peds that make us excellent at this. So when we approach the peds, when we approach the peds, we're going to know what we're doing and be comfortable with this process. So each role has some responsibilities and things that you need to be thinking of. What you need to look at in the first three positions are that this is designed to give the BLS providers or that initial engine company ownership of CPR. When we approach the code, the purple section here is kind of the scene considerations, what you need to be thinking about when you come up on a code. These aren't very different from what you do already. BSI, scene safe, I have my PPE, my appropriate PPE for this patient. Now, everything in red on the code is something that addresses one of the key interventions in the study. So we're going to treat every patient in place. We're not going to grab them and run. We're going to create a 360-degree access to the patient so that we can do excellent care. Officer, you're going to get on the radio and you're going to call full code, letting everybody know what they're walking into. Okay. Now here's where we set up some solid goals. The expectation is that we're going to be able to hit our key interventions in the first 2 minutes, especially when we have 5 personnel on team and one of them being an ALS provider. The key to getting this 2-minute goal is the pre-arrival planning. When you show up and when you get dispatched and you get that patient information from dispatch, you set that plan for your crew so that when you walk through the door, you can just get patient side and go to work. That means iGel gets placed in the first 30 seconds, right? That means we're treating in place. We're making that 360-degree access to the patient. That iGel is in place. We're breathing for him. CPR is in place and is continuous as much as possible with only 3-second interruptions. The defib pads get placed, and in that first 2 minutes, you'll be able to analyze and see whether or not that patient needs to be defibrillated. If you have ALS on board, you'll get the IO and you'll get the epi placed. All these things can be done in 2 minutes if you have the engine and medic show up at the same time. And we're not just making this up ourselves. This is right out of the American Heart Association, the 2020 BLS provider guidelines. You'll see that all these positions are very similar to the positions that we're talking about in the model. You have a compressor, you have a thumper, you have a breather, and you have a button pusher on the monitor. This is the golden triangle of CPR. You've got positions 1 through 3 covered in that scenario. We're going to have a team lead. We're going to have somebody on the med box. And all of these positions have defined roles and expectations. So again, those first 3 positions, chest compressions, airway, and monitor, are the golden triangle. That's that engine company that arrives on scene first. There will be exceptions to this. This is kind of built for the 90%. But then the medic unit gets there. You have the RD on the med box, and you have the medic as the team lead. And then any additional crews that come in fill in the last positions here at documentation officer, and then the resource pool. So we want to set up our scene the same way every time. We want the initial person and compressions to start on patient left every time. And this is important for a couple reasons. Number one, this is that logistics improvement. It's going to take a little bit of getting used to that. We're not just going to place the patient, and if you're on the right side, you're going to do compressions there. We want to start with compressions on patient left. And when we get into the medic unit, we'll kind of see why that's important. Airway goes to the head and needs the green box, the O2 sling, and suction, right? The monitor person is going to need the monitor. The officer is going to have the tablet set to CPR, and they're going to give that to the monitor person. They're going to take their phone and get the metronome and hand that to the monitor person, or just place those 2 items near the patient's legs. When the medic gets there, the RD is going to go and start working at the med box. The medic is going to be the team lead and have the ability to go anywhere on the scene that they need to in order to take care of patient care. What this effectively does is it makes the amount of people that the medic or the team lead is supervising is just these 4 people at any one time. When additional resources get there, that liaison officer is going to be the only person to talk to the medic. They're going to show up, say, hey, do you need anything? Nope. Okay. I'm going to start talking to family. then anybody else that comes to scene is going to only communicate with that liaison officer. That takes the load off the medic that's the team lead so that they can focus only on the care directly in front of them. So that first position is the compressions position. So this on the cards, it's really the how, or it's the what you have to do. This is the what you're going to be doing. And we're going to talk a little bit about the how-tos, right? So in position 1, we want to be doing chest compressions on adults, 2 inches of depth on the chest compressions, on peds, 1.5 inches, but really the goal is at 1/3 of the chest, of the depth of the chest. The ideal rate per AHA is 100 to 120, so we're going to set the metronomes to 110. So we're going to try to get that ideal rate of 110. We want to allow for complete recoil on chest compressions. So if you're on the chest, we're not leaning on the patient when we're coming up on the compressions. We want to be able to get a credit card in between our hands and the patient's chest, allowing that heart to fill completely. So one of the indicators is when are we going to use hand compressions and 2 thumbs? And think generally, if you can get your hands circumferentially around the chest of the patient, that's when you can go to 2 thumbs. Other than that, you're 2 hands on the chest. There's no more one-handed compressions. It's 2 hands directly over the patient going straight down. We'll talk a little bit about this more because the whole goal to this is to try to decrease the amount of time off the chest. So if at our CPR checks every 2 minutes, if we can reduce that to 3 seconds off the chest, that's the key that is going to improve our cardiac perfusion pressure. That's going to show in some of the statistics that we're going to be drawing off of these and giving you feedback on later as we start to analyze these.
So position 2 is pretty much what we talked about in the first part of the class. These are your list of to-dos. You're going to place an eye gel. You're going to breathe once every 3 seconds. You're going to give them oxygen. You're going to get your suction out. And then the one thing that's on here that we haven't talked about yet is you're going to be responsible for making sure that a length-based tape is actually measured on this kid, right? Pre-arrival guide is going to go for our first 2 to 4 minutes, our initial actions. But at some point, we need to verify that this length-based tape is accurate. And so as the airway person, since the measurement starts at the head, you're responsible for ensuring it happens. Doesn't mean that you get up and go to an orange box and grab the tape. You just have to communicate with people. So when you arrive to scene, the equipment you need is the O2 sling, green airway box, portable suction. If there's a medic unit on scene with you, grab their PED box. The one thing I want you guys to remember, as we talked about, don't overinflate the lungs. It's 1 breath every 3 seconds, small ventilations. How do you know? We don't look at chest rise because we're doing chest compression, so it's hard to see. So absolutely get that end tidal monitor on. And yeah, I think that's it on the airway.
All right, and then we go to position 3. And like Jeff talked about in the last class, is that we want to set up the monitor in this configuration as much as possible. If it's an all BLS crew, we don't get to see this option because you're going to have it in AED mode. The second a medic gets there, we can move this into manual mode, and then you're going to set this up to this screen. All right, so the monitor position is probably the busiest of the positions for the first 2 minutes. Okay, you have a lot that you need to bring to the party. You need the life pack. You need the officer is going to be handing you the ESO, where you're going to be interjecting the interventions. You're going to be marking the interventions. You're going to have the phone and the metronome, and you're going to start the metronome moving, and you're going to make sure that it's tracking and that your compression person can hear it and see it. All right, one thing that I want to address really quickly too. The card itself, when you look at it, is really busy. There's a lot of information on this front sheet. That doesn't decrease our cognitive load. But if you're assigned to compressions, your world just got really easy. You ignore everything else on this sheet except that spot. You own that spot at compressions. If you're the airway, you just live in that airway role. So don't worry that how busy this is initially. This is so everybody can have a reference when they get to a position. But this is, if you're airway, that's your world. Okay? So so the first things that you're gonna need when you're on position 3, you're gonna apply the pads, you're gonna prep for a defib if possible. You're gonna start the app. You're going to set your monitor up with EKG, SpO2, and end tidal. You're going to have the ESO, so you'll be hitting interventions as they come. Medic gets there, you're switching to manual mode. You're going to be placing the pads. There's a lot to do. So then we start getting towards the minute 45, and this is where the interplay between position 1 and position 3 happens. So what we found is that as we practice this model, this interaction between positions 1 and position 3 is the toughest one for us to dial in. But this is where we can reduce our time off the chest down to 3 seconds. So this is really a critical part. And it's going to look something like this. So Jeff is patient left, he's on compressions. I'm patient right, I'm on the monitor. I've got the ESO tablet in a place where Jeff's going to be able to reach it. I've got the phone app out, and that's the metronome that's running, and I've got the monitor right here within reach of position 1.
We don't have a table right here, but 99 times out of 100, if you can set these things down by the feet, it makes it a lot easier for me to access in a minute, as opposed to reaching across a head where we've got ventilation.
And we'll definitely demonstrate that more when we get out to the scenarios, because this is where a lot of the practice is going to happen amongst the crews. Okay, so we get to a minute 45. I'm going to dial this patient is 3 months old. I'm going to dial them down to 8 joules on the monitor select. I'm going to hit charge. This is going to charge up. My hand is going to go to the femoral pulse. You've got good compressions with CPR. Okay, I confirm his compressions. I've now located that femoral pulse with his compressions. So when the medic tells us to do the rhythm check, I'm at the pulse, so I can tell whether or not we have ROSC or not. Now we're counting down. 15 seconds is down around 5, 4, 3, 2, 1. The medic is going to say, stop compressions, hold compressions. I have no pulses. And then the medic's going to say, we're in asystole, dump the charge. I go to compressions, and he'll dump the charge. That's how that interchange back and forth is how we minimize that time off the chest. There's going to be a little bit of reaching over the patients. As we practice this, we're going to get better at it. All right, do we want to talk about the app? Yeah, yep.
On the ALS engine that you have today, what's the best position for the medic?
Number one, we're not going to tell you directly this is the best place ever and that this is where they have to be. But it seems that if the medic is at the monitor position, they're more familiar with the monitor in general, and that's probably where they can direct and coordinate care the best. So having a medic in that monitor position is good. What you saw in the video is that it was a full BLS engine company. Having the officer at compressions initially was beneficial for a couple of reasons. We still have to worry about scene safety, right, and the scene, but you're needed in one of these roles. So you're either going to be compressions, airway, or monitor. If you're on compressions, you have the ability to kind of have your head up and head on a swivel, looking around what's happening. If mom's upset, if we have like big brothers and uncles are coming out here to be angry with you, you can have your eyes open and see what's happening, right? No or yes? Okay, so we're going to talk about the app. So pull out your phones really quick, and your rig phones should have the CPR Tempo app on them. They got pushed out to the phones. Some of them might be missing, but it looks like this. So when you start the app, it's going to look a lot like this. Okay. So it's going to have, once you start the metronome, it should be set at 110, and the epi should be set at 240. What you have the ability to do is when you start CPR is you hit the defibrillator. And you'll notice that what that does is it grays out that button. This is going to be our 2-minute timer. This is going to be what makes our decision on when we're going to charge the monitor and when we're about ready to switch compressors and when we're going to do our rhythm analysis. So you can see it's counting down. When it comes to 15 seconds before it gets full white, then you're going to say, hey, you're going to charge that monitor, and you're going to get your hand on the pulse, and you're going to be communicating with that person on compressions and say, are you ready to make the switch? Get your medic's attention. Say, are you ready to check the rhythm? And then the medic is going to make the call on whether or not when we're going to stop compressions and when we're going to switch. If I was on monitor and he was on compressions, We're gonna either shock or not shock, and then I'm on the monitor. Now I go to compressions. So when they say resume compressions, it doesn't mean the person that was doing the compressions resumes the compressions. This is the switch. When we do get to the epi, same thing. You hit that epi button, and this is a 4-minute counter. Epi is prescribed at 3 to 5 minutes. We're going to split the difference. We're going to set it at 4. That means that every other 2-minute cycle is when we can expect there to be an epi delivered. And so the reason we have it set up in this fashion is that there have been numerous scenes where you're the medic and you're thinking about all these other things. You're like, man, when was my last epi? How long since my last epi? Here's where, if you'll only give an epi if this has made it all the way around the clock and it's back into the white and it's counted down the 4 minutes. And your RD or whoever's at the monitor can say, hey, yep, you've hit your 4-minute time. You're ready for an epi anytime. Okay. So that's what this app looks like. We'll play with it a little bit in the scenarios.
So moving on to position 4, medic unit has arrived. Logically, as it happens most of the time now, the RD becomes the person on the med box. So you know you're going to you're dispatched to a pediatric cardiac arrest. You've done your pre-planning in the medic unit with your partner. As the RD, I know my job is to bring in the Pelican box and immediately get an IO set up. Nobody has to tell me that. That's what I'm doing. If it's an adult, it might be an IO, it might be an IV. Have that conversation with your medic. But peds, we're going straight to IO. So you set the box down near the feet, you get the IO set up, you hand it to the medic, and I immediately turn right back around. It's a cardiac arrest. We know we're going to give epi, so I'm going to start to prep my epi. 1 to 10,000. It's a pediatric. We don't want to use the preload as far as like push that entire thing, so you're probably going to need to find a 1 cc or a 3 cc syringe with a needle so that we can draw out of that preload like it's a vial, so we can get an accurate dose of med that we're going to give to the patient and not risk a muscle memory overdose. You get the epi ready, you hand that to the medic. Then you're going to turn right back around. Anything that comes out of this box is your responsibility. If the medic says, hey, I want some amiodarone or lidocaine or calcium or whatever, that's your job to find that medication, get the appropriate syringe and needle, either draw it up or hand it to the medic so he can draw it up. Fluids, right? You got to spike a bag. You got to get your pressure bag set up, a Volutrol, all these things that is your responsibility. It's also your job to cross-check the medications for the medic with the Pierce County dosing card. So on that card, there's milliliters listed on there. So really all you have to do is go, oh, we're giving epi. And the medic says, yep, right here, I got to give 4 milliliters of 1 to 10,000 epi. This is what I'm giving. Is that correct? Yep. Boom, that's good. That's what I see. So now we reduce risk of error because the medic has a little bit of a cross-check. In addition, really the last thing that you're responsible for comes out of that med box too, and that's a DEXI check, right? It's your responsibility at some time in this code to get a blood sugar and let the medic know if it's a problem or not. For neonates under 1 month of age, 45 is kind of that bottom range of normal. For peds in general, it's 60, and adults we use 80. So that kind of summarizes the RD's role.
All right, the team lead.
Question, Jack. Auto pulse is specific to adults. We didn't put it on this card because it's specific to peds. So what I will say about that, we're going to use this for adults because it's our practice. So pulling the auto pulse in here is up to the team members. I think it's a good idea on certain patients. It just needs to be organized.
I know this is for peds, but it's basically the same thing for adults, right?
Yep,
Yes.
exactly.
Yep.
There's very little that's different. The auto pulse is one thing that's not on there. And there's a little bit of an algorithm in AHA as far as 2-minute epis, but the medic should be aware of those things. Everything else fully applies to adults.
So position 5 is the team lead. So as team lead, you're going to be doing everything that as a medic that you normally do as a team lead. You're coordinating all care for this patient. You're the backup that if the reminder to the monitor person that once you arrive on scene, you want that monitor put in manual mode. It's not gonna. The problem with having it in AED mode is that time for analyze is too long. So once the medic is there, you are the analyze button. You can make that determination on whether or not you need to defibrillate in less than a few seconds, and you can get your CPR person back on the chest. So the quicker that you're out of AED mode and into manual mode, that is going to improve you're going to improve your coronary perfusion pressures. So you're going to be looking at whether or not you need to get that IO in place. So you're going to be getting that IO access. You're going to be giving that epi if you need to. You're determining whether the patient is shockable. You're that evaluation at the rhythm change of the rhythm. Okay, the things that you're going to want with you. You're going to want to bring these cards in with you. Oh, I didn't talk about that. These cards will be in multiple places. So the first place that they will be is on every life pack in the defib pouch. So these will be on every code. These will also live in at the officer seat on the engines, so that you can make that pre-arrival plan, right? So this same card will be in the officer seats and the right seat on the medic units. So the medic unit can also be prepping their thoughts on what kind of dosing they want to be thinking about. So when the medic does get to scene, they're going to want a few things. They're going to want the pediatric checklist, and there could be 3 of these on scene in this scenario, right? An engine, a medic, and a life pack is there. So you're going to want this. You're also going to want the Pierce County dosing card from the medication box. You want that in hand so that you can be making all the best decisions you can with the best information. You're going to be making a determination on whether or not you need to get a tube, right? An ET tube. And here's where we're going to set the expectation is that on all pediatrics, 0 to 18, the expectation is that you're going to place an iGel, and that iGel will be in place all the way to Mary Bridge. The only reason that we would not have an iGel in place is if something was failing at the iGel. You are not able to ventilate effectively with the iGel. Okay? So I want to say that again. This is really important for the medics. Our expectation is that the iGel is in place on all peds and is maintained all the way to Mary Bridge.
In addition to that, I will say if the iGel is not working, we want you to have a high consideration for going back to a bag valve mask. It's fast, done correctly, it's very effective. If you're unsuccessful, then and only then should we really consider placing an ET tube. We've already shown we're not very good at it, right? So let's go with the things that we are good, that are quick, and we can reestablish an airway first. The questions come up, well, does that mean we're really not intubating adults on cardiac arrest as well? And I'll say this, we're dropping an iGel right away, right? What we need to do is need to make sure we still have enough attempts as medics. If we only rely on RSIs, we might get 3, 4, 5, 6 RSIs a year, right? We need some more practice at that. So thinking about that, we always think what's best for the patient. In these scenarios, if we're 15 to 20 minutes into an asystolic code, there's been no rhythm changes, the chances of this patient having any sort of neurological outcome are very, very slim. I would advise you to try an ET tube on these patients. Maintain your skills. It is a better airway. Secondly, if you have a patient who gets ROSC or you're going to transport with ongoing CPR, you need to make a determination on whether you're going to stick with an iGel that's working or whether you're going to replace it with an ET tube. Number one, I want you to do the best thing for the patient, right? If the ET or the iGel is working great, maybe we should stick with that. That might be the best choice. If there's something that you think would be improved by an ET tube, higher airway pressures, better control of that airway, by all means, you have the ability to do that. But we first want you to do an airway assessment. Do I think that this will be a difficult tube, right? If you do, you might want to stick with what you've got. If you don't, and you feel like you need to give it a try, go for it. But remember, what we're not going to do, iGel's working great. You're not going to go in, try and place a tube, and then look up and tell your providers to stop chest compressions so that you can place this tube. Because they're going to look right back at you and go, dude, put the iGel back in. We're not stopping chest compressions, because they're owning CPR, right? We're also not going to live in that airway for a long time. We already have an airway that's working. Let's go back to it. And the last thing we want to make sure that we're not doing is causing any trauma in the airway to get the ET tube. Because if we leave it the same way it was before, we can put that iGel back in and it'll work just fine. Does that make sense? Okay. So position 6, this would be your second in engine company typically, and the officer from that engine. He's going to arrive on scene, and it's his job to get a lot of the information. We're already getting interventions, real-time data on scene at patient side through one of our tablets. He's going to bring in another tablet, whether it's his or he grabs the one off of the medic unit and brings that in. That's totally fine too. But he's going to walk in. The first thing he's going to do, he's going to come up to the team lead and say, hey, do you need anything?
No, I'm good.
And if he doesn't need anything, fantastic. If he needs something, he's going to turn to the resource pool that came with him, and he's going to assign them those tasks to go assist airway, go in and rotate out on compressors. After he takes care of that initially, he's going to go find the family, and he's going to get basic patient information, demographics, name, age, birthday, patient history, medications, allergies, all that stuff. He's going to be responsible for any communication from the team and the patient area back to the resource pool, which may be down the hallway or in the kitchen or someplace else. We're not trying to intermingle all that stuff.
So what this
Just to add in, go ahead.
So what this can do is that this may mean that we're going to have 2 EPCRs running that need to get transferred to the medic unit's tablet, right? So the initial engine officer has made their tablet into the interventions tablet. The second officer in position 6 is going to be getting the demographics information. You may need 2 numbers to transfer to that medic unit's tablet, and you can get all of this information will transfer except for the signatures, and you can transfer multiple tablets worth of information to that medic unit's tablet. One way you can circumvent this is that if you're the second in engine, you can grab the medic unit's tablet and leave yours out and just start getting the demographics on the medic unit's EPCR itself. That way we only have 1 transfer. Good? All right. Then we're going to go to position 6 or 7 through 9, the resource pool. Everybody else that comes to scene that's responding to the logistics or the liaison documentation person. So you can imagine that, especially with the IGLs, having a second person at airway is going to be beneficial. So additional personnel that come to scene may be used primarily in that airway role. Secondarily, as our kids get older and compressions becomes more physically demanding, we're going to be thinking about rotating people in and having fresh compressors. The other roles that you might think that you would have would be focused on patient movement. So getting a mega mover to patient side, getting the gurney to the door, having somebody turn the medic unit around, get ready for transport, prepping the back of the medic unit to receive a patient. So those are things that you might get assigned as the resource pool. Oh, and always bring a second O2 sling to the scene, like extrication in the fire scenes. Always bring something to the scene so that you have additional equipment to help when we're running out of O's on those scenes.
And just to touch on Jack's question earlier, the other thing you could add on here in an adult arrest is take a look at that medic unit and see if that auto pulse is already on scene. If not, that's a great thing to bring as well. So moving on to the rest of what's left on this checklist. So we go to a cardiac arrest. The expectation is if we do their job, we give this patient the best chance for survival. And let's say we get pulses back. Great. Now what do we do? Well, we've got a quick reminder for the medics on scene. How do I approach a ROSC scenario? What are the important things to do? Number one, what I want you guys to all think about is that if we get ROSC in a patient and they're going to lose pulses again, it's likely going to happen pretty close to right after you get ROSC. That perfusion status is pretty poor. So what we don't want to do is immediately get pulses, pick this kid up and run out and be halfway down the hall when he rearrests and have to figure something out, right? So here's your plan. Take a few minutes and get everything set right where we are. If they lose pulses, we're in a good place to start compressions again. So you get ROSC, get a full set of vitals, temp, lung sounds. If it's appropriate, get a 12 lead. Blood pressure. AHA now recommends doing a quick seizure evaluation. Was this kid having a seizure before he arrested? Does he have a history of epilepsy? Do you see any evidence that he might still be seizing neurologically? If he is, get on the phone with Mary Bridge. Ask him what they'd want you to do. Does he need pressors or fluids? Do we need to sedate this kid because now maybe, or this adult because now maybe they're starting to breathe? What's your options for that? Do you need a second IVIO, right? These are all questions that you just ask yourself real quick. Before we move a patient, we want to print the monitor screen. Super important because that captures everything that says, I had a good end tidal, I had this for an SpO2, and this was the rhythm he was in. We move that patient to the medic unit, we get back, we're done moving, we print the screen again, it recaptures everything. It says everything is the way I wanted it. That's going to save you. We'll drop down to the yellow box here. These are all straight out of Pierce County protocol. Consider transport with ongoing CPR if these things are present, right? If they're under 30, If it's drowning, hypothermic, overdose, refractory shockable rhythms. End tidal CO2 increase is on there as well with ROSC. Obviously, we transport those patients. But if we have a jump in our end tidal, we may not feel pulses immediately with that, but that's a patient who likely has gotten return of circulation. It's just not enough to feel. That's a patient that needs to go to the hospital, okay? So last but not least, we gave you guys a decision-making tool on when it's okay to transport. We're telling you to treat in place, so when can I leave? If you accomplish everything in the transport benchmarks, that's your clue that says, I need to go to the hospital now, or I can go to the hospital now. So airway is optimized, or at least as good as I can make it. Breathing is optimized, circulation is effective, or as good as we can make it. The circulation, if you're transporting with CPR in place, you've got a plan to make sure that CPR is effective while you're moving this patient down the hallway and the stairs into the medic unit. You've gotten access, whether it's IO or IV. You've given some epi because it's a cardiac arrest. Somebody has been designated to talk with the family to arrive at the emergency department, specifically in the case of children. We want a parent to either accompany the medic unit, maybe we drive him down, or another family member or friend transports them. Everybody who's involved in moving this patient is on the same page, on the same sheet of music. And what I would advise is these eye gels are fairly precarious. They're not as stable as ET tubes. So disconnecting end tidals, disconnecting wires from the monitor, and moving a patient with a BVM is probably your best bet to do it safely. As soon as you get to a stable place, you hook everything right back up. And then last but not least, that the medic has either started to address the H's and T's, or there's a plan to continue to address them throughout transport. When you've accomplished all those things, this might be 4 minutes. It might be 15 minutes. Then you can transport, okay? So we have a quick video to run through. It's about 5 minutes long. It's an engine and a medic arriving on scene at the same time and accomplishing the checklist, and they're under a 2-minute goal. I think it's about a minute 45 when they get epi on board.
I got no breathing, I got no pulse. Looks like a full code. Bring that table over. Here we go. All right, we have a 3-month-old patient. With our pre-arrival guide, this will be a color gray.
Color gray.
I got compressed. Steve, will get me set up with an IO and then epinephrine. We're going to be doing 0.04 milligrams, which is 0.4 milliliters of epi.
Got it. I gotta return that. I'm gonna get the diaper out.
They're gonna turn.
Good compliance, good chest rise.
Good. Yep. Yep. Rip the diaper.
Ventilate.
Okay.
Ventilate.
Ready for end tidal.
Anybody know what happened? Family around? Everybody leave? Sounds terrible.
Ventilate.
Thank you. Alright.
Ventilate.
Alright. Good draw, good flow on the IO.
I have 0.1 milligram,
Ventilate.
1 to 10,000 epinephrine ready to go.
Okay, let's just compare to our cheat sheet here. Alright, we want 0.4 milligrams, which is 0.4 milliliters. Perfect.
Ventilate.
Got 1 minute of compressions on. 1 minute of compressions on.
Ventilate.
Okay, epi is pushed. Good. I'm going to hand you back the 1cc syringe.
Ventilate.
Let's get a blood glucose.
Nancy coming up.
How are we doing on airway?
Good
Ventilate.
compliance, good waveform. Pressure bank ready to go.
Perfect, thank you very much. And we're in manual mode, correct?
We're in manual mode.
All right. How are we doing on compressions?
Ventilate.
Got 30 more seconds.
Okay, let's make sure we have a pulse with compressions. Are you able to do that, Paul?
Do that.
Okay, you can check a brachial or a femoral.
Ventilate.
Checking a brachial. What do you want the charge to be?
Ventilate.
It's going to be 8 joules, which is going to be the lowest setting our monitors have.
You
Ventilate.
got 15 seconds.
There you go. 15 seconds, let's charge it up.
Got a pulse.
You got good pulses with compressions? Okay. All right, do you still have a pulse? No pulse, all right. Begin compressions.
I'm gonna grab a Dexy.
Thank you.
Ventilate.
All right, let's see here. So we have compressions going very well.
Ventilate.
And we have confirmed we're still in the gray. Perfect, still in the gray. Good end tidal, iGel's placed.
Here's your card.
Metronome is on, perfect. Got the IO on.
Dexy is 84.
Dexy's 84, thank you very much. Okay, gonna compare here with the pediatric card.
Ventilate.
Very good. Not a shockable rhythm.
Ventilate.
And as long as we have good compliance, we don't need an endotracheal tube yet.
Good compliance.
Ventilate.
Perfect. All right.
Ventilate.
Got 1 more minute.
1 more minute.
Good brachial with
Ventilate.
Second engine's arrived. I'm getting some patient
information.
Do you need anything? Yes, if I could get someone to come switch out for compressions, that would be great.
Ventilate.
compressor. Thank you.
Oh, you got 40 more seconds, and then Matt's gonna take over for you. Understood. 40 more seconds.
Ventilate.
Good, good compressions.
30 more seconds.
Ventilate.
All right.
Ventilate.
Okay, 15 seconds.
Ventilate.
Confirm, charge that up. Confirming pulses.
Pulses?
I got pulses.
Good pulses with compressions, okay?
I'm gonna dump the charge. Hit stop compression. Still got pulses.
Ventilate.
You have pulses, good. Looks like we have end tidal waveform, perfect. We have a return of spontaneous circulation. So what we're gonna do, let's get a full set of vital signs, including the blood pressure, all right? Thank you for getting lung sounds, perfect. Still have good waveform. All right, we're gonna do a 12 lead EKG when you get a chance.
I'll do bilateral.
Second engine, can we get ready for transport? Come up with an extrication plan?
We'll get you an extrication plan, get the medic unit turned around.
Awesome, thank you.
Give me your blood pressure.
Perfect. All right. Let's see here now. Go through our return of spontaneous circulation checklist. Some transport benchmarks. We have an optimized airway, good. Breathing is adequate. We have pulses and getting the blood pressure, circulation. We already have adequate IO access. We've given our first dose of epi. Can we make sure that the family has transportation to the emergency department?
Mom's going to be riding in the medic unit.
Awesome. And then we're going to package the patient. We'll review the H's and T's on the way in. Any questions? Perfect.